Welcome everybody for this morning session. And why we have chosen this topic is because this is a new monitoring modality and a modality of investigation which is very, very important from the patient's point of view as well as from the cardiologist, intensivist point of view, but also it is very, very important from the anesthesiologist point of view. So slowly we should start learning more about this. And first and foremost, I've chosen directly Trans-Thoracic echocardiography views acquisition because once you develop interest and once you start knowing that what is the importance and what all problems or what all pathologies you can detect from this, you will feel interesting to learn more and more of echocardiography. In the following sessions, we may see about nobology and various conditions, how we can diagnose and how they will make a difference. Our diagnosis makes a difference in anesthesia management. But as of now, to start and inculcate your interest in transthoracic echocardiography, let us see how easy it is to acquire these images, and later on we can see how to interpret these images. So as we all know, echocardiography is safe. It is a very, very safe modality. It is non-invasive. The best part of it is repeatable. As many times you can repeat it, and it is real time. Whatever is happening inside the heart is on the screen, and therefore our management, just like the invasive blood pressure monitoring, what we do, you manage bit to bit variations, right? And you don't allow your patient to succumb for anything. So is with echocardiography. Echocardiography is real time, beat to beat management can be done. Echo provides a substantial structural and functional information about the heart. It can be applied in perioperative period, intensive care units, emergency situations, trauma, as well as resuscitation aid. What does echocardiography actually assess? It assesses the contractility of the heart, which we very well know as ejection fraction of the heart. It also assesses the chamber sizes and hypertrophy, which is very important while managing the obstetric cases like peripartum cardiomyopathies. So we have to be very well versed with this, and a lot of information can be gained with echocardiography about the patient's conditions. Then valvular dysfunctions, like the stenosis and the regurgitations, cardiac tamponade, very important, and pericardial and pleural effusion. Now, coming to the echo views as such, there are mainly 4 views to name: the suprasternal view, left parasternal view, apical, and subcostal. But as an anesthesiologist, we have to be very well versed only with the 3. That is the left parasternal view, which is just on the left side of the sternum, as the heart is situated on the left side. Just keep your probe on the left parasternal side, where exactly I will be telling, and that is the left parasternal view, which gives a lot of information to us. Next is the apical view at the apex bit. So when you keep your probe on the left parasternal view, you assess the heart from the anterior side. When you see the heart or keep the probe apically, you just see the heart from the apical side, that is from below. Okay, and if you are unable to assess both from these 2 windows, like for example, you say the patient is obese, or the patient is just post-surgical patients who have poor windows due to edema or something. If the patient has subcutaneous emphysema, if the patient has bandages or dressings, drains, if you are not able to see your windows through these 2, the left parasternal or apical, then comes is the subcostal view. In the subxipoid region, you keep your probe and you get the subcostal views, which are same replicas of the above views only. And so mainly these 3 views are of importance to us. Now let us start with the first view, that is the parasternal long axis view. Now how do we position for this? Patient position has to be left lateral position. Usually you see in echocardiography room, if you have seen, the patient is always positioned in the left lateral manner. That is because the heart falls on the left side near to the chest wall. A probe is on the chest wall, anteriorly placed, and the heart falls, so it comes closer to the chest wall. That is the idea, and you get better views. Then transducer is placed in the 3rd to 5th intercostal space on the left side of the sternum, near the sternum, just near the sternum. Okay, and the main part is the orientation probe, or the orientation marker on the probe has to face on the patient's right shoulder. Here's the patient's right shoulder. So this is only one view, which is called as P-lax view. In this view, the orientation marker is towards the patient's right shoulder. Okay, rest all views, the orientation marker is not towards the right shoulder. It may be any other direction than the patient's right shoulder. Okay, so this is the only one view, parasternal long axis view, also called as P-lax, wherein the orientation marker is towards the patient's right shoulder. This is very important because if you change the direction of the probe, the orientation marker, the replica or the other side of the image comes, and then somebody or the novices can get confused with the structures. Okay, I'll be telling in detail how to identify which chamber so that this confusion doesn't occur, but still the thumb rule is that orientation marker has to be right towards the right shoulder in P-lax view. Now, what does this P-lax view tell us? This is the P-lax view. Once you get this view on your screen, it is very important to identify the chambers. They are very easy. Here is your probe. Yes, at this angle. This is the chest wall. Immediately, always below the chest wall is the right ventricle. Whenever you have seen cardiac surgery also, immediately you see a big right ventricle. Yes, whenever the sternum is open. So this is the right ventricle which is there. And then the other chamber is the left ventricle. This is the interventricular septum. The left ventricle has an opening, that is the left atrium, and the valve is the mitral valve. Okay, this is the anterior mitral leaflet, which is always in vicinity with the aorta, is the anterior AA, like that we can remember. So this is the anterior mitral leaflet, this is the posterior mitral leaflet, and then the aorta opens into the LV, the LV opens into the aorta. So this is the aortic valve. Okay, now ECG is always connected to know which phase of the cardiac cycle we are interrogating in the echocardiography. But if you don't have ECG, this is the way that we have to see the left side of the heart and see the mitral valve. It is open, it has to be the diastole, because the mitral valve opens in diastole and LV fills in diastole. Okay, and when the mitral valve is closed and aortic valve is open, it is always the systole, because during systole the LV will contract and the blood will go out into the aorta, is the systole. So whenever the you can remember any one valve, whenever the mitral valve is open, it has to be diastole always. Okay, so these are the structures what we see in P-lax view. So what do we assess in P-lax view? The LV systolic function, that is the ejection fraction, can be very well assessed in P-lax. Then dilatation and hypertrophy of all the chambers, interventricular septal hypertrophy, mitral valve and the aortic valve functions, descending aorta dilatation, I'll be telling on this, pericardial and pleural effusions as well. So now this is a beautiful picture wherein you can diagnose descending aorta dilatation and pericardial and pleural effusion apart from all the other above mentioned heart structures. So as I told you, this here is our probe, here is your chest wall, then has to be your RV, LV. So interventricular septal, its hypertrophy can be assessed. This is the posterior wall, or nowadays it is called as inferior wall. Okay, so this is the LA aorta. Now see, this is the aortic valve, right? So this is the ascending aorta. So here comes the arch of aorta, not seen here. And then when it goes directly here, this is our descending aorta. So a circular shaped structure is seen, which is the descending aorta. Anything that is anterior to, this is our anterior part, right? So anything that is anterior to, or just remember in front of descending aorta, is always the pericardial effusion. Okay, so this is your pericardial effusion. Then a glistening structure will be seen, that is the pericardium. And then if you have any collection, that will be the pleural effusion. So here it is the mild pericardial effusion, and in this picture it is the pericardial effusion, and also pleural effusion is seen, which is moderate to severe. So that is how this pericardial and pleural effusions can be diagnosed. Now, that was all about PLAX view. Now coming to the other view, your probe has to be on the same at the 3rd to 5th intercostal space on the left side of the sternum. Just what you have to do is you have to just rotate it to the 90 degrees. The transducer is rotated to 90 degrees clockwise to get the short axis of the same structures. Okay, so this is called as the parasternal short axis view of the aorta actually. Okay, so now your indicator or the orientation marker is towards the patient's left shoulder. What do we see in this? It is just like it was the long axis. This was the long axis of the heart. Now we have cut it into 90s and you are going to see the short axis of the heart. If you remember a watermelon, that is the long axis. If you cut it, you see the red part, inside part, that is the short axis. So now I'll be telling you how this is the aorta in the center. Okay, this is the aorta. It shows as leaflets. This is called as a Mercedes-Benz sign. This is called as a Mercedes-Benz sign. When the aorta, when it is closed, aortic valve is closed, it has to be the diastole. When it is open, the blood is gushing out, it has to be the systole. Okay, so this aortic valve, it is open or closed, you decide the diastole and the systole. Okay, so again, your probe is here. Fine, this is the chest wall. Beneath the chest wall will be your RV. So this has to be the RV. Okay, and this is to your tricuspid valve and the RA, interatrial septum and the LA, that is the left atrium. And in front, this has to be the RVOT, pulmonary valve, main pulmonary artery, and then its bifurcation. That is seen in another view very nicely. So as of now, in parasternal short axis view, these are the structures which we can very well assess. If you're if you want to go into the depth of this, or if you're cardiac anesthesiologist and you want to assess more about the aortic regurgitations of the aortic valves, there is something like you know the importance of each of the leaflets of the aortic valve. Also, for that you have to know the nomenclature and which cusp is situated where. Like if this is the RVOT, this is always the right coronary cusp. Okay, just adjacent to the interatrial septum is always the non-coronary cusp, and here is your LA, that is the left atrium. So this is the left coronary cusp, and this is of importance in cases of aortic regurgitations or if you are repairing them. Now what we have done is we took first PLAX view, that is the parasternal long axis view. Then we cut it to 90 degrees, and we have seen the parasternal short axis view, right? So what we have seen is now the parasternal short axis view we have seen anteriorly, like aorta. Now what we have to do is we have to just tilt our transducer downwards. Okay, so if this is our heart, then now you have to just see what is below the mitral valve. Like you have seen the aortic valve. Now just place your transducer at the same position where it was and tilt it now towards the left hip to interrogate the whole of the mitral valve apparatus. So now when you do that, you get the parasternal basal short axis view. Basal is at the base. Okay, at the base is situated the mitral valve. So this is the basal short axis view. So what do we assess in this? These views are of particular importance if you want to assess mitral valves. Okay, so this is the mitral valve which will be seen, and it is seen very distinctly in the images. So this is the anterior mitral leaflet. Okay, our probe is here, so this has to be the anterior side always. This is the anterior mitral leaflet. This is the posterior mitral leaflet. LV is seen. This is the LV. These are the walls of the LV, the interventricular septum, and a part of right ventricle is always seen. Okay, so this was about the parasternal basal short axis view. Now what you do, you tilt further towards the left hip, that is downwards, and you see the inside of the LV. Okay, So when you see the inside of the LV, what you see now, the base, that is the mitral valve, is seen. Now you see the papillary muscles. So this is the anterolateral papillary muscle. This is the posteromedial papillary muscle. Okay. There is a lot of importance to this view. This view gives us importance about the regional wall motion abnormalities. In echocardiography report, many times when you are dealing with any ischemic heart disease patients or coronary artery disease patients, or any post CABG patients also, they may have this regional wall motion abnormalities. What is regional wall motion abnormalities? Pertaining to some region of the LV is regional, wall is wall of the LV, motion is movement, and abnormalities. So any abnormality in the movement of that region of the LV gives us a lot of information about the coronaries of that patient, and what and how we have to proceed with our management, that can be decided. Okay. This view also tells us something important, which is known as like kissing papillary muscle sign. These papillary muscles, they come together when they are contracting. That's called as kissing papillary muscle sign. It is pathognomonic of hypovolemia, and fluid resuscitation has to be done in this. Okay, so this is a LV wherein two papillary muscles are seen nicely. This is also a reduced or moderate LV dysfunction case, but the LV is seen as such, and the LV cavity is also seen in this. Now in this, if you see, the LV cavity is obliterated and the papillary muscles are coming close to each other in the center, right? So this is something which tells us that the patient is hypovolemic and needs fluid now. So that is the importance of parasternal mid-papillary short axis view. You just further tilt the probe and you get now the apex of the LV. So this is the apex of the LV. Similarly, regional wall motion abnormalities can be detected in this as well. Now, this was all about P-lax and P-sax view. Parasternal short axis is called P-sax view. So we are now well acquainted with the P-lax and P-sax view. Okay. Now, if can we derive some more information about the heart? So we have to look at the heart from the other angle. So what is that angle? That is from the apex impulse, or from the apical point. So what you just do is place the patient in the supine position now, or supine, or even a left lateral tilt. Now, being an anesthesiologist, we just cannot be adamant on the thing that I want the patient in left lateral position, because in the perioperative period, that is not possible always, right? So so we should be actually acquainted with seeing the echo in the supine position. Also, we have to be acquainted with doing it with right hand or left hand, because you never know your patients are in which side of the anesthesiologist, or the surgeon is on which side, or even the ICU, in the ICU, if it is feasible to do from which side. So we have to be acquainted with all these things. And now what we have to do to acquire the apical 4-chamber view, keep the probe at the apex impulse or in the 5th intercostal space in the left mid-clavicular line. Okay, and the orientation marker is now towards the patient's left shoulder. Very easy to get this view. And what information do we derive from this view? Basically, this is the view which we get at the apical 4-chamber view. How do we decide which is which chamber? I'll tell you properly in this. The largest, usually and normally, the largest chamber is the LV always. Normally, I'm saying the largest chamber, the globular chamber, and the chamber which is forming the apex is usually the left ventricle. It is very important, because we have to diagnose, because many times we don't get normal patients, right? Like for echocardiography, or in whom we go for assessment of this. So we have to be very, very particular. If the patient has pulmonary hypertension, or cardiomyopathies, this may not be the condition. That is why we have to know how do we identify the chambers. So the largest, the globular, and the apex forming ventricle is usually the left ventricle. Okay, the other ventricle, which is usually smaller and triangular, and which normally does not form the apex, is the right ventricle. Fine. There are two things which will distinctly say that this is right ventricle. If I say this globular and apex forming, you may get confused and you may not even be convinced with this. But now the convincing two signs are the right ventricle will always have a whitish structure, a rope-like structure, which is the moderator band in it. So a moderator band is always present in the right ventricle. LV doesn't have this moderator band, and in the RV, it is distinctly seen in all the patients. Okay. The next thing is that the valve of the RV, that is the tricuspid valve, is a bit apically situated. This is the apex. Okay. And you will always see it lower down. Then it is never at the level of the mitral valve. It is lower down than the mitral valve. And the thing is always the valve of that particular chamber goes with it always. So even if you have any congenital anomaly, or you're unable to diagnose which is which chamber, you have to see the valve. The valve which is apically situated is the tricuspid valve, and then this has to be the RV always. So apart from the globular, larger apex forming, there are two more signs, the moderator band and the apically situated tricuspid valve, which will distinguish these two chambers. Fine. Then coming to atria, the left atrium will always have the opening of these pulmonary veins. Okay. The right atrium doesn't have them. So apart from the four chamber, we can assess the mitral valve, the tricuspid valve, the interventricular septum, the interatrial septum, pulmonary valves, flow through the pulmonary valves, the pericardial effusion, everything and so much can be assessed in this apical four chamber view. So this is a very, very important view, and it is quite easy to get these views also. So the same what I was telling is what do we assess in apical four chamber view is the ventricular function, that is the ejection fraction, contractility, dilatation and hypertrophy of the chambers, pericardial effusion. Fine. Now what do? We just, from the same wherever our probe is, we just angulate it anteriorly towards the head of the patient to open the fifth chamber, which is the aorta. Now this is the apical 5-chamber view, and this is the aorta which is open. This is the LVOT, aortic valve, and the ascending aorta is seen. Okay. So this is our apical 5-chamber view. Okay. LA, LV, the LVOT, aortic valve, and the ascending aorta is seen here. Now these are the additional views. If you want to go into more detail, you can assess these views. Otherwise, apical 4-chamber and apical 5-chamber suffices for most of the information. Just from the same position, you rotate the probe counterclockwise, and you get these two chambers. The RA-RV disappear, and you get the LA mitral valve and the LV only. And walls of the LV in this view are the anterior and the inferior wall of LV. So you get different views to assess all the walls of the LV in case of regional wall motion abnormalities. For the 3-chamber, again the LA, LV, and the aorta opens up. Now, sometimes you may find very difficult, or you may get poor windows in this, but then to our rescue comes the subcostal view. So we have to be very well acquainted with this subcostal view, and this is very easy view. What you have to do is you have to just keep your probe in the subxipoid region with your orientation mark towards 3 o'clock position. That is not towards the right shoulder. Just keep it away from the right shoulder, and there you are. What you can see is this view. This is the liver, and this is the RA, RV, LA, LV. Okay. Now you will say why this is RA. I can say it as LA. Okay. But again, your structures, if you don't see this as globular or triangular, and if they are abnormal, they are equally sized. The main thing is, if you manipulate your probe little bit, you can see some tubular structure opening in the RA, which is always the IVC, that is the inferior vena cava. Okay. So from the subcostal view, very well we can see, or we can interrogate RA, tricuspid valve, RV, interatrial septum, interventricular septum, LA, mitral valve, LV, and also the IVC. So subcostal view, this is the liver, and you can see this is the RA here, and beautiful IVC is seen here in long axis. The whole length of IVC can be assessed here. Now coming to the last view, that is the suprasternal view. A lot of information can be gathered from this, and just keep your transducer in place on the suprasternal notch, and your orientation marker has to be towards 1 o'clock side, that is just away from your right shoulder. Okay, and what we could assess is the full arch of aorta, the brachiocephalic artery, the common carotid artery, the left subclavian artery, descending aorta, right pulmonary artery, and the LA. This is of particular importance when the patient has IABP, because the tip of the IABP should not occlude the subclavian artery. Yes, so this is of particular importance in these patients, and this view is of very much help in them to assess the subclavian artery and the IABP position. This is one more view just for your information. This is called as the RV inflow view, or also the bicaval view, wherein you get the PLAX view first and then turn your probe or tilt your probe towards the right hip to get this beautiful view, which shows the tricuspid valve RA-RV and also the SVC and IVC, also called as bicaval view if you focus on the RA part. Then this is the RV inflow outflow view. This is the aorta in center, and this is the RVOT, pulmonary valve, main pulmonary artery, RPA and LPA. Here you can see the pulmonary artery, the main pulmonary valve, the main pulmonary artery, RPA and LPA is seen in this. So that was all about acquisition of transthoracic view from my side today. And thank you so much for joining in and for patient listening. Thanks a lot.